Hi, my name is Taylor Vipon, and this is a brief education intervention to improve healthcare-specific financial literacy in nurse practitioners. The healthcare system in the United States is enduring the most significant pay-for-performance initiative in history, as value-based care and cost containment replace the traditional fee-for-service reimbursement. Providers are being expected to provide high-quality, cost-effective, and financially accountable care for their patients. The healthcare system is interconnected, and changes and challenges affect every segment of the system. Financials are the core of any organization, and financial indicators are a way to assess which direction the organization is going, whether it can sustain or whether it will fail. So what is financial literacy? Financial literacy is defined as having a combination of knowledge, ability, attitude, and behavior that is used when making financial decisions. The evolving healthcare system is a complex environment, and basic financial literacy has been perceived as a necessity for individuals to succeed in increasingly complex environments. The current reforms are creating enhanced need for all perceived leaders or aspiring leaders in the healthcare to be financially literate. Applying adequate knowledge, ability, attitude, and behavior to healthcare financial discussion and decisions can enhance leadership in this complex healthcare system. Direct care providers have a significant impact on the success or failure of the reform efforts. In turn, the ability to be successful in the reform efforts impact the overall organization. This then impacts the ability to provide services and resources to the population. So this all starts with direct care providers. Financial discussions and decisions are becoming mainstream in the practice setting as performance-based reimbursements and increased focus on population health promotion and prevention require the provider's direct and active involvement. So your decisions directly influence patient quality outcomes as well as the associated costs. Attaining the financial literacy competencies are not the same as learning a skill. Instead, it's achieving the ability to connect the financial literacy concepts to your performance, which has the potential for continuous growth and improvement. According to the leadership competency and health leadership competency models, outstanding leadership skill in nurse leaders must include financial competencies. Inadequate literacy and practice concepts can create financial uncertainty and instability and have an overall impact on the ability to provide patient care. Since nurse practitioners' healthcare decisions can directly influence patient quality outcomes and associated costs, increasing financial literacy can positively influence these decisions. $1 gained by capturing revenue has the potential to deliver 8 to 10% in operating earnings. This is a significant impact on the hospital system. Thus, providers must always consider reimbursement for achieving the quality measures. Nurse leaders need to take responsibility to be involved in, engaged in, and consider taking leadership roles in decision-making and implementation of healthcare reform efforts. Aim to consciously identify and improve each of the lacking financial literacy qualities of knowledge, ability, attitude, and behavior. Pay-for-performance initiatives such as the Triple Aim and the Merit-Based Incentive Payment System are demanding changes in how healthcare professionals deliver care, and all healthcare decisions are increasingly analyzed for their economic impact. Decisions are no longer based solely on the volume of services or solely on the patient satisfaction with care. Rather, cost-value analysis of quality care is continually assessed. I'll talk more about the pay-performance initiatives shortly. Why is healthcare financial literacy so important now? I suspect it's always been important, but why is being involved and striving to improve financial literacy in healthcare so imperative at this point? Because an estimated $200 billion is predicted to be wasted annually on excessive testing and treatment. This involves providers ordering the same grouping of tests out of habit rather than based on evidence, blood draws being repeated due to providers' inability or lack of perceived responsibility to access the earlier results, and providers practicing defensive medicine out of concern for malpractice litigation. Waste and partitioned financing in healthcare organizations has been a historic problem in the United States, and the Pay for Performance initiative has developed measures in an attempt to contain this problem. On the pre-intervention questionnaire, I posed the question about which financial concepts or terms are applicable in your work environment as a nurse practitioner And many of you mentioned the ACO, which is great, and that is one of them listed here on the screen. I chose 5 terms concepts total to discuss that are being used continuously and consistently in your organization, and they rely heavily on your involvement. The first one listed is pay for performance. So pay for performance indicates paying for the quality of services rather than the volume of services. This changes the historical payment method of the United States healthcare system. Performance scores are assigned based on various criteria, including quality of patient care, the use of electronic health records, the cost of care, and practice-based improvement efforts. These performance scores, which are highly dependent on what the provider does in the clinical setting, are then used to provide financial rewards or penalties to the organization. This affects all stakeholders, including administration, the provider, the support staff, as well as the patient, because the patient is the consumer. The second term here is accountable care organization, or as you know it, is the ACO. It is a new model of payment under Medicare that consists of groups of providers that work collaboratively to provide high quality, cost-effective, and financially accountable care to the population they serve. Ultimately, these new models of payment under Medicare have shifted the financial risk toward providers because it's no longer the volume of the services being reimbursed, rather the value of each service. So the providers are accountable for the quality of care, which makes them accountable for the organization's reimbursement. The third term and concept is chronic care coordination. Many of you have probably heard of this one and use it, but I feel like the financial implications have not been adequately highlighted. So the ultimate goal of chronic care coordination is to help the patient navigate the complicated healthcare system. This is important to not only keep them as healthy as realistically possible, but also to decrease their overall cost of care. Navigation help may include closing gaps in transitions of care and care delivery between providers or between provider visits, assisting with end-of-life planning, and focusing on overall wellness promotion. Care coordination has been linked to improving patient outcomes and lowering Medicare costs. Managing chronic care is extremely important because patients with 5 or more chronic conditions make up a whopping 79% of Medicare costs. The last 2 terms and concepts are a little bit more tricky, and they are starting to sound less applicable to direct care providers. But the provider is the fundamental driver of these concepts, so I feel that they're very important. The first one is the risk adjustment factor. Sometimes it's referred to as the RAF. It does not necessarily sound like something that the provider would be concerned about. However, it is directly related to the degree of patient illness, which is determined and coded by the provider and determines whether adequate resources will be available for high-risk patients. The risk adjustment factor is a numerical value that is used to identify the patient's health status. This numerical value then determines the overall reimbursement. The 5th term and concept listed is the hierarchical condition categories, or HCCs. This is the model behind the risk adjustment. An HCC is a category of disease type, such as diabetes or CHF, that may have multiple ICD-10 codes. Each ACC has a risk adjustment factor. So, the importance to the provider is to make sure that the proper HCC category is selected so that it is specific enough to portray the complexity of the patient. For example, if the patient is being seen for a complication of diabetes, such as for wound care, be sure that the coding reflects a diabetes complication rather than simply wound care. Quality performance has become and will continue to be an essential component in overall reimbursement and improving population health. Provider leadership is very important to enhance quality performance and improve the efficiency and expenditure of the organization's funds. Accordingly, quality indicators in healthcare are increasingly connected to the health system cost. The next 5 slides are on quality measures. You may have heard about these measures in various situations and may or may not be fairly familiar with these, but I want to explain a little bit about how the measures work and again why the provider is a principal element. The aims of the quality measures are disease prevention, chronic care coordination, manage high prevalence conditions, and encourage patient safety and patient caregiver engagement. As previously mentioned, the provider's performance in the clinical setting directly influences financial rewards or penalties to the organization. The 2018 quality measures include 31 measures separated into 4 domains, and many measures, including the use of imaging studies for low back pain that will be discussed in an upcoming slide, have exclusions. For example, if a CT is ordered for low back pain and the patient has a diagnosis of cancer, it is considered an exclusion. The key to remember is the importance of the clinician's documentation. The first domain listed involves better health for the at-risk population. Achieving measures in the diabetic population requires a combination of making sure the hemoglobin A1C is under control, as well as encouraging the yearly eye exam. The other measures include control of hypertension, initiating aspirin therapy for patients with ischemic vascular disease, and achieving depression remission. Direct clinical data is used to evaluate whether these measures are being met. That means that the clinical charting and codes must be as specific and descriptive as possible because the data cannot be augmented or expanded in any way beyond the direct provider's documentation. The next domain includes the preventive health measures, which likely look pretty familiar, and include mostly screenings, immunizations, and follow-up measures. Ensuring patients are up to date on breast and colon cancer screenings, flu and pneumonia vaccines, as well as measuring body mass index and developing a plan for follow-up, screening for tobacco use and follow-up on a cessation intervention, implementing the clinical depression screen and developing a follow-up plan, and initiating statin therapy for the prevention and treatment of cardiovascular disease. Again, direct clinical data is used to evaluate the success of the preventative health measures. These measures direct your attention once again to care coordination and patient safety initiatives. The evaluation of measures in the care coordination and patient safety domain become a bit more complex. The first two, identifying future fall risk and post-discharge medication reconciliation, are measures that are again evaluated from direct clinical data. The other measures are claim-based. This means that the results of the measure are placed on a claim prior to submitting it to the Centers for Medicare and Medicaid. Charting in the clinic is still very important and must be specific and descriptive because data cannot be added after the claim is already submitted. These measures include use of imaging for low back pain from an X-ray, MRI, or CT within 28 days of the diagnosis, unplanned readmissions for patients with diabetes, heart failure, or multiple chronic conditions, readmissions for any condition within 30 days following a discharge, re-entry into a skilled nursing facility within 30 days, admission for conditions that are considered acute prevention quality indicators. These include dehydration, bacterial pneumonia, and urinary tract infection. And lastly, successful use of the electronic health record technology. The last domain is the patient caregiver experience. This is determined based on the Consumer Assessment of Healthcare Providers and Systems Survey sent out by the Centers for Medicare and Medicaid Services. These measures are all claim-based and aim to evaluate the patient experience of care received. The 8 measures in this domain include timely care and appointments, provider communication, the patient's rating of the provider, access to specialists, health promotion and education, shared decision-making, health and functional status, and the management of patient resources. But if providers are doing a good job achieving quality measures, why is the maximum allotted reimbursement not being achieved? It's because the fee-for-service declines and the pay-for-performance continues to grow. This means the focus is on the complexity of the patient rather than complexity of the service, and proper coding at the highest level of specificity is the best way to eliminate possible gaps in care and make sure that money is not being left on the table. For example, each chronic condition must be billed yearly because under the HCC model that we discussed earlier that includes the risk adjustment factors indicating patient complexity, the memory of last year's chronic condition is erased. So as the provider continually manages chronic disorders year after year, don't document history of a condition such as history of COPD because this indicates that the condition is no longer treated and you will not be reimbursed for a condition you are not managing. Instead, document COPD controlled with Advair. This signals that you continue to manage this condition and will be reimbursed accordingly. Again, make sure that all conditions addressed within a visit are documented and use the most specific codes as possible. This will make the risk adjustment factor more accurate, which will lead to reimbursement based on the resources needed to care for your high-risk patients. The question here is if the healthcare system is interconnected and interprofessional collaboration is stressed at being important, why is there such a gap between nursing and healthcare financial concepts? The studies that I reviewed listed these following factors as the barriers most likely creating the gap between nursing and finance. Lack of motivation, the evolution of the nurse leader role that mandates financial literacy, insufficient training in the workplace, insufficient reference tools to help nurse leaders understand financial concepts, the lack of financial concepts in nursing education orientation, the lack of ownership in the nursing profession of their financial performance, and I believe that the last one is the most significant in the conflicted feelings between role of caregiver and money analysis. In the pre-intervention questionnaire, I received a really good answer when I asked what you feel is the biggest barrier. And the statement was that they went to school to help people, not to care about reimbursement. And I'm going to cover a little bit more of this in the next few slides. The key to achieving quality care and cost containment in this pay-for-performance system relies on the willingness of the providers to involve themselves in change initiatives. ACOs rely on the direct care providers to eliminate irrelevant care, improve care coordination, and contain costs. Primary care providers in particular have a significant impact on the success or failure of the health reform efforts. According to the competency models in healthcare, outstanding leadership skills in nurse leaders must include basic financial competencies. So how is the best way to demonstrate this accountability and financial literacy? Take responsibility for identifying areas of waste and utilize necessary critical thinking skills that include financial literacy to implement and monitor improvement plans under the Pay for Performance initiative. Continue direct efforts of long-term cost containment measures, including the previously discussed quality measures such as screenings, medication reconciliation, and documenting advanced care plans, and realize the benefits and impacts of your efforts for population health as well as for the viability of the organization. As nurse practitioners grow in number and prominence within the healthcare system, they are progressively in a good position to influence patient decisions as well as the evolution of the healthcare system. When I built the pre-intervention questionnaires that I keep referring to, I tested them on a nurse practitioner who is also a professor at a university. An important question that she asked was, as nurse practitioners become independent across the United States, will insurance companies adjust reimbursement to 100%? Nurse practitioners typically receive a portion of the reimbursement rate that physicians receive, and I believe that she posed a very important question that requires not only involvement from nurse leaders, but the healthcare financial literacy to do so. Be engaged in reform efforts and help influence larger decisions within the healthcare system. Basic financial literacy within the healthcare system is the next concept to conquer in order to influence future healthcare delivery decisions and shape the overall dynamics of the healthcare system. In summary, the take-home message really highlights the key factors discussed within the presentation. The gap or disassociation between nursing and finance needs to be eliminated. And I think this starts by tackling the barriers, particularly lack of motivation, lack of education, and the conflicted feelings between role of caregiver and money analysis. Because providers familiar with and more proficient in financial literacy ultimately have a greater ability to influence future healthcare delivery decisions. This gives you a greater ability to advocate not only for patients, but also for the overall nursing profession. Accurate coding with the hierarchical condition categories will continue to have a significant impact on the ability to characterize the patient's condition, achieve adequate reimbursement, and provide patient-centered care. Remember to utilize care coordination whenever it applies, because 79% of Medicare costs come from patients with 5 or more chronic conditions. Finally, achieving quality care in the pay-for-performance system, along with sensible expenditures, will lead to healthier populations and viability of the organization. So by taking responsibility to understand this process and the benefits to the healthcare system, you can help eliminate the disassociation between nursing and finance. Thank you everyone who participated in this project. I appreciate you giving your time toward this topic matter, and I hope that you took something valuable and useful from it and you enjoyed the presentation. The next 7 slides contain a list of the references that were used to build this presentation. Thanks again.